This is Still a Part of Us, a podcast where moms and dads share the story of their child who was stillborn or who died in infancy. I'm Winter Red.
And I'm Lee Red.
And in this episode, we're actually interviewing Dr. Jessica Page. She's a Maternal Fetal Medicine Fellow at the University of Utah Health. And she's talking to us all about stillbirth and autopsies after stillbirth and all the research that she is doing. And we're excited to have her on today.
Winter, we're coming upon the 1-year anniversary of this podcast.
Which is the second birthday, would be the second birthday of our son, Brandon.
Yes.
So we're going to do things a little differently in July. We usually, as you know, if you've been listening to the podcast, we usually put out an episode on the 1st and the 15th of every month.
We try to.
It can be a little tricky, especially with the coronavirus situation. It's been a little nuts over the last few months. So,
yes.
But we are going to be sharing our stories of Brandon's birth on the 23rd of July. That's his birthday. And so we wanted to, at least for me anyway, I've needed to have a little bit of courage to do this because this is, I'm always impressed with our moms and dads that come on and share their story of their child, because I think it takes a lot of bravery and courage to share that story. So we're gonna try and get a little brave. We're gonna courage and share Brandon's story on the 23rd. So it'll come out just a little bit later than usual.
Yeah, and we hope that this has been helpful. It has been a year. It's been wonderful yet hard for Winter and I both to have to, it's been wonderful to reach out and to meet and to sort of build this community of people who can support each other. But it's also hard because, we're talking to people who deeply love their children who have passed away.
Yeah.
And it sucks.
It sucks. We've all been through really terrible things, and it really is, it brings home that I guess we're blessed to have known our children for even just a short time. So
if on the 15th you're looking for an episode, come back in a week.
Yeah, that should be good. So
a week and a day.
Yeah.
Well, thank you so much. As a word of caution to our listeners, this discussion contains emotional triggers of stillbirth and infant loss. Please keep yourself emotionally and mentally healthy and seek help if needed. Hope this helps someone out there.
Okay, we are here today with Dr. Jessica Page, and we are extremely excited to have you on today. We know that you have quite a background in stillbirth research especially, and so we were excited for our audience and for us to hear what you have to say about stillbirth and what kind of research is out there today. So welcome, Dr. Page.
Thank you so much for having me.
We're so grateful for you to come on today. So. As an introduction, can you tell us a little bit more about yourself, where you trained, and who your mentors are? Anything that will give us a little bit about who you are?
Absolutely. I was raised in Idaho and then completed my undergraduate and medical school education in Oregon. And then I came to the University of Utah for my obstetric residency training. And following that, I've stayed on as a Maternal Fetal Medicine Fellow, and will be taking a faculty position as well at the university in Intermountain. And I have been participating in stillbirth research since I was a medical student. Continued that through residency and fellowship, kind of getting more into it as things progressed in my training. And first starting out in larger databases and then doing more kind of like refined work in stillbirth cohorts themselves in residency and fellowship.
I was just going to say, how did you get started initially in stillbirth? And you said that there was a lot of data points and in your residency and fellowship, but was there an initial draw? Was there in your personal history, any draw to stillbirth, or was it just an interesting topic that you felt as an OB you should get into?
I think as I went through my training, later on in medical school, going through my obstetric clerkships, I started to care for patients and families who had experienced a stillbirth And prior to that, I think that as you go through your medical education, you are exposed to things that you never really had thought about that much or knew was as prevalent of a problem. And taking care of patients going through this experience, I realized, one, that this is an ongoing issue in even developed nations such as the United States, and that two, it was incredibly devastating, and somewhere that I felt like, gosh, if this is something that I could help with more, meaningfully than just interacting with the patient, in the experience itself, but maybe long term helping to, know more about it, reduce the risk or prevent it, wouldn't that be a good thing? And so I initially worked with a mentor, the chair of the OB department at Oregon Health and Science University, Dr. Aaron Coy. I worked with him initially looking at different populations of women, both primarily in national birth certificate databases. And we would look at, different maternal conditions such as like risk factors related to age or medical problems such as like diabetes or high blood pressure. And then saying, okay, when's the best time to deliver people on a population basis to help decide, or to help to reduce the risk, one, of having a baby die on the inside, or two, have a complication of prematurity that would lead to complications and potentially infant death. And so that's how that all started, was just really a clinical interest and recognition of, gosh, this is a bigger problem than I had ever, realized. And then coming to residency at the University of Utah, I worked a lot with Dr. Bob Silver, who's the chair of our department here and is a very well-known stillbirth researcher. And a large study that had been conducted at many different clinical sites about a little over 10 years ago now. But they basically studied women both with live births and stillbirths. And it's one of the best characterized and largest cohorts of women with a stillbirth. And that has been a really rich data source for us to look at risk factors, characterizing different populations of women, just a real wealth of information in terms of trying to better understand this problem.
Wow, that is a lot. Thank you so much for describing that. With that particular study with Bob Silver, did you guys collect data? So you said live births and stillbirths as well. And so it was probably surveys that were happening after the fact and kind of collecting data about the moms and as well as the outcomes of the babies. Is that kind of generally how you guys have done that?
Yeah, so that study, people were enrolled at the time of delivery.
Mm.
And so there were some demographic factors that were collected in this forms of surveys from moms. There wasn't a lot of like surveys in regard to like long-term follow-up of those families, but basically they were characterized in regard to like their social and demographic issues, medical problems. And then people in both cohorts had screening in regard to like maternal labs, and then like looking at the placentas and thorough evaluation of the baby and delivery characteristics of each group, so that you could compare them to each other.
Right. That's great. Because I've seen a bit of research in stillbirth, but it's usually just looking at kind of retrospective, which means going back and looking at charts that have already happened and gathering that information. And also, I didn't realize this for a while, but some states don't even require reporting of a stillbirth. And so that probably has potential of gaps in knowledge.
Absolutely. That really confounds a lot of the retrospective data. And in fact, when you look at fetal death certificates, different states have different rules about gestational ages at which they issue them, how well they're captured, particularly if it's like an out of hospital or rural birth. And so that data can really vary. One of the big strengths of this study, which it was called the Stillbirth Collaborative Research Network, is that it was a prospectively collected case control study. And so that really adds to the strength of the data.
When you're talking with the parents as they're enrolling into this, they have had a stillbirth. How do you go about talking about getting an autopsy? Do you go through the whole, these are the different types of autopsies you can do, or this is what your child will look like coming back for the burial? What is your your process in talking to parents about getting their children into the study, and then also talking about the autopsy.
Yeah, absolutely. I sort of approach each of those things a little bit separately. And just to make sure that I haven't created confusion, that study is over.
Oh,
That one's no longer going on. We just use the data, retrospectively in secondary analyses. But we do have ongoing prospective, just cohort studies of families who have experienced a stillbirth happening at the university. And then I'm working on getting that going at Intermountain as well. So that we do still have ongoing studies that we recruit patients for. And the whole topic of evaluation and counseling after a stillbirth is an interest of mine, and something that I feel really strongly about, because this is sort of the crucial point at which we can interact with families to help them through this experience, to gain information and empowerment as they go through it, and to really feel like they've been, well counseled in this setting. It's obviously an unexpected and devastating moment. And so I think the very first point is just really trying to meet a family where they're at, and not rush the process of making these decisions. Sometimes there's a little bit of a time sensitive nature in regard to, it's harder to do some things weeks down the road. But certainly it doesn't have to be all decided in the first hour that you're in the hospital. And so I try first to, obviously just sit down with families, go through the situation with them that we're in, in terms of helping them to understand where we're at. And then as they are ready to talk about, okay, what's the next step? Because there's a lot of next steps to think about. There's, when are we going to deliver and meet our baby? What are we going to do to figure out what happened? What happens after this? And then subsequent pregnancy. In regard to evaluation, there are a few tests, depending on the clinical situation that each family is in, that are really helpful. So we used that stillbirth database that I discussed previously to help us determine which tests most often help identify a possible cause of death for the baby. And then a group in the Netherlands did a similar study just prior to ours. And both of those studies showed that the most useful tests were doing placental pathology, where specially trained physicians will look at the placenta, both just looking at it, with their eyes, and then also under a microscope to help them decide, okay, what do we see here? Are there changes in the placenta that would say that maybe my baby wasn't getting enough oxygen? Are there, signs that there was an infection happening? That maybe something like an abruption where it separates from the wall of the uterus, thus impairing blood flow happened. There are so many clues that can come through on placental pathology. And it really is helpful in, depending on the study you read, somewhere between 60 and 90% of cases.
Really?
Yeah.
That seems a lot higher than I expected. Okay.
Right. And I that has to be taken with a bit of a grain of salt, because any time you are trying to decide what test is most helpful, it depends on what classification system you're using for cause of death. And there's a boatload of those, actually. There are a lot. But in general, they all are very dependent on placental pathology classification. Or findings.
Right.
And then the other test that was most helpful is fetal autopsy. And this, I think, is one of the hardest things to talk with families about, because you not only just lost your baby, but now we're talking about doing an autopsy for your baby, and that just seems inconceivable. And I think that, for me, what I do in talking about this with folks is I approach it as, our ultimate goal, one, is to help you through this experience, and two, to try to understand as best we can what happened to your baby and why, and and what could have potentially caused this. Because one, that can help to provide some emotional closure for families. And then two, it helps us in just determining what's the recurrence risk of having another baby die. How are we going to best take care of you in your next pregnancy? And from a, like a long-term research perspective, are there problems coming up that we don't appreciate yet that are targets for future prevention that we should be studying closer? If most of stillbirths are not explained, we really are sort of stuck in terms of trying to figure out what to target next. So, to have a well characterized population and identification of causes of stillbirth is really important so that we can better target high risk populations for prevention measures. And that's where I also, it kind of ties into like a talk about ongoing studies that are available. So, kind of in backtracking to, and then back to the autopsy discussion, I absolutely go over the different options for autopsy, and try to talk about this in a way that is a little bit more kind of focusing on the potential yield in terms of figuring out what happened, and then keeping an open mind as to the different, each family's background and personal beliefs, and in kind of meeting them where they're at in that process. So the standard full autopsy, obviously has the highest yield. You get the closest look at baby. And I think an important thing that not a lot of patients know is that once that autopsy is complete, any incisions made on the baby are hidden by like normal clothes.
Mm-hmm.
So it's not as if you are going to have your child return to you and you couldn't look at your baby, or have an open burial or something like that. Like that's not, I think families feel like, oh my gosh, I don't want my baby to be harmed or disfigured. And that really is not the case. You can also definitely limit incisions. So, you could say, I don't want anything on the head, or I don't want any incisions on the baby. So you could do sort of a non-invasive approach where you could do just imaging, and we can work with our pathologists to do like x-rays, to do MRI. Those can take a little bit longer because sometimes it takes some more coordination, but that's definitely something we can work with our pathology team to accomplish. If you still you want to do some workup in terms of, are there any things going on for our baby that we didn't know about previously, that those are an option, but would not give you as much information. Sometimes when, some of the things that you can find on an autopsy are that like, oh gosh, my baby had an infection, and you could see that like in the liver and the lungs, or, there were findings where the organs had abnormalities that are suggestive of a particular genetic syndrome, and testing could be done to better, figure out what syndrome may have been happening, based on those autopsy findings. So there's a lot of things that can be learned from it, and certainly there are lots of options in regard to how much or how little you want to do, but just with a decreasing sort of yield. The less we do, probably the less we're going to pick up.
So
But it still has value.
So it sounds like that it really is just a matter of asking questions, because I know in talking with a lot of other lost moms and dads, they declined an autopsy because the first thing they think of is they're going to cut up my baby, and it just sounds just awful. But
Yeah.
I didn't realize that you could get an MRI or an X-ray. That's surprising to me. That's great.
Yeah. And sometimes even just the pathologist doing an external examination of the baby can be very valuable too, to see like, were there any, just kind of characteristic features of different genetic issues or malformations. Sometimes that can be useful. So certainly some is more informative than none, and that there are lots of options within there. And if you don't know right away, say that you're having a hard time deciding, we can do it later too. You can even do it after a baby has been embalmed.
Oh,
So it's not like it's off the table. And I think that, I'm working on right now, development of like an educational system, one for providers and for patients, because I think people feel uncomfortable with this on both sides. Providers, this is one of the hardest things to counsel on because we feel so bad about
Yeah.
this situation. We want to help you through it as much as we can. And I think that when people don't know all these details about, the autopsy, how useful it can be, and then all the different components of the workup too, they don't feel as comfortable counseling families, and they don't do it as well. And so one piece of this is improving provider education, and two, having an interface for patients where you can have either printed materials or video materials that you can access on your own time, either in the hospital or home, to go through and reference and make sure that that information is available to you in sort of a standard and consistent way. When I was, in the course of doing this research, there are studies about patients and families' experiences with dealing with fetal autopsy and how they, found the counseling and the aftermath, surveys of patients later, and what they thought about that. And it was interesting to me that a much higher proportion of patients in those studies felt that they had not been adequately counseled. And I think that speaks to the emotional trauma of this event. Like, it's really easy to miss something someone tells you when you've just had the worst day of your life. Like you might have missed that sentence here or there. And so, as providers, we need to make sure that we provide consistent and, sometimes repetitive counseling, coming back, revisiting the topic. And then two, that when they surveyed patients to see, what did you regret? Did you regret doing an autopsy, or did you regret not doing an autopsy? It was more common that people regretted not doing the things, not by a lot, but I think it's just that feeling of, gosh, did we have missed information? And certainly it's not always a slam dunk. We're not always going to find an answer from it. In our study, an autopsy was helpful in about 40 to 60% of patients in finding a potential cause of death. So it is one of the much higher, yield things that we can do, but nothing's 100%. So, and really the most important thing is having really good characterization of the situation around the pregnancy and around the death. What kind of, was there an infection? Were you having bleeding? Was there something going on that would help point us in the right direction? Those are the most important things. And then we can better order tests to help maximize the chances of finding a cause.
Gotcha. I'm excited for your development of materials for providers and for the families, because it really was, when we were approached about this, there was so much stuff that went over our heads. We were just in shock, and so I appreciate that you acknowledge how difficult that situation is and how there is a need for repetition.
Absolutely. I mean, even in the most, kind of routine moments in patient care, talking about, I don't know, we talk with everybody, say, just in the course of normal care, about delivery or prenatal vitamins or this or that, like people forget just normal things because you've got a lot on your mind. And, so in a situation like this, that's so challenging and unexpected, I think that's a crucial moment for having information available at multiple time points and in multiple ways.
Yeah. As you have, well, one question really fast on a follow-up. So you said you were working on those materials. Do you have any expected kind of when those are going to come out and when the training might be happening?
Well, I'm working on that project now. I'm actually applying for grant funding as we speak.
Great.
So I'm hoping in the next year we should be organized with this. And I'm hoping to have it in both the Intermountain and university systems.
That is wonderful. I just know that I'm sure a lot of our listeners will be like, yay, we need this in our system. So I think that is great that you're doing that. And then I'm curious, with all of these evaluations and tests that you do, have you come to any conclusions in your research about that would change your way of practicing maternal fetal medicine, and what you would say to your patients, like that maybe have had a stillbirth, or is there, or even in prevention of a stillbirth, any big trends that you've seen that you're like, gosh, you definitely need to, obesity is a contributor. So trying to get your weight down, or, I mean, are there certain things that you recommend to your patients that you've seen?
Yeah. I think stillbirth is tricky in this regard because there are a lot of things that are associated with it in regard to risk factors, but none of them have strong predictive value. Medical complications like hypertension, diabetes, obesity, those definitely, they all have been shown in population studies to increase your risk of a fetal death or a stillbirth. And so we absolutely try to modify risk factors that are changeable, such as like how well your diabetes is controlled, how well your blood pressure is controlled, stopping smoking, things like that, that those, getting everything in the best possible state in regard to those risk factors is definitely one of our primary goals. And I think a big piece of this too is sort of just ongoing patient contact and care. I think many pregnancies in the US and worldwide are unplanned, and so it's really great if we, as healthcare providers in general, just have access to patients and can help them think about these things in a sort of longitudinal or long term fashion so that people are thinking, like, oh, yeah, I guess I maybe could get pregnant in the next year. What should I do to sort of be ready for that? Or if they're thinking, gosh, I'm really not in a good spot for being pregnant, I should maybe have some contraception. Like things like that to help people be, empowered and in charge of their reproductive futures and prepared for that, particularly if they have higher risk conditions that could put them at a higher likelihood of having a, horrible complication such as stillbirth. We want those patients to be in the best possible situation. One thing that we do that's really helpful is we'll do like what's called a preconception visit, where we'll meet with patients. Either it could be someone who's never had a baby but has medical issues or things that need to be discussed, or somebody who has had prior pregnancies that have had complications, whether it be a stillbirth or like a preterm birth or anything of that regard. And we, as maternal fetal medicine doctors, will meet with those patients, go over their history, and then talk about, here's what we could do based on what we know now to best optimize things for a good outcome in your next pregnancy. So I think that's a really key thing just in general, to help make sure that people have a good game plan. And following a stillbirth in particular, I think, in that setting, like a patient has had like the ultimate loss of control of their situation of their pregnancy, right? Like you were doing everything that you thought that you should be doing, and things ended up horribly and you lost your child. And so I think having a roadmap and a game plan to help you feel like, okay, we at least have this, we've talked about it, we've laid out a plan that can give kind of an element of, I don't know if control is the right word, but at least a sense that you're proactively engaged in trying to, make things as safe and optimal as possible for the next pregnancy. Pregnancy and parenting in general are sort of low control situations, but to our best ability, we really want to help patients to feel empowered and to feel like we have really addressed all their concerns and past, complications.
I like that idea of having a roadmap. It feels a little bit more comforting to
Mhm.
know that your doctor's on the same page as you and you know which direction you're going. And obviously it's not completely preventable, but having that little bit of reassurance is helpful. So I assume that there's a lot more monitoring done if a family has experienced a stillbirth or some sort of fetal loss during the next pregnancy.
Part of the care of the next pregnancy is really informed by what we think caused the
Mm.
prior stillbirth. And so that's where really optimizing the workup and having as much information as possible is nice. But in any case of prior stillbirth and in particular unexplained situations, we have sort of a general guideline by which we do increased surveillance during the next pregnancy, and it's kind of multifaceted. And some of it is agreed upon by like our national guidelines, and then locally we sometimes modify that a bit more based on the the like specific patient situation. And so in general, we obviously like to see all patients early on in pregnancy to make sure things are going well early on, to really establish a good due date. And for patients going through pregnancy after having after losing a baby, it can be everyone. I think everyone is individual. Some folks feel like, I want more visits and more fetal viability or heart rate checks. I want to make sure everything's looking good, and that can be comforting. Some families feel like, gosh, my interaction with the healthcare system was sort of traumatic. I kind of don't want to go in and be
Mm.
seen too much. I would rather you know minimize some of that, and you just do the things that you think that are needed. And I think that can really be individualized. And we always want everybody to have a detailed anatomic ultrasound of the baby at about 20 weeks or so. And then going from there, we often will add in, some additional ultrasounds to look at growth. Sometimes we'll do what's called the non-stress test, where we listen to the baby's heartbeat on the monitor for about a half hour or so in the third trimester, just to be sure that there's no evidence that the placenta is not working well at that point in time. And then traditionally, we would deliver, sometime around 39 weeks or so, but that sometimes varies.
So you would recommend a little bit not going to 40 weeks or on. You would recommend 39 weeks.
39 weeks is definitely agreed upon as a time at which delivery is appropriate, particularly in this clinical setting, because there have been large population studies looking at both maternal and neonatal outcomes following that gestational age. And we essentially know that there's not more maturation benefit to be gained on the baby's behalf past that point. So, the absolute risk of something going wrong, after that point, if you say you wanted to go to 40 weeks or even 41, odds wise, you're unlikely to have a complication, but you're also unlikely to derive further benefit from being pregnant. So we usually offer induction or delivery at that time.
Gotcha. Oh, that's very interesting. I think I saw a paper about that, that 39 weeks was kind of like right there is good.
Yeah, it's kind of a sweet spot. And certainly in a uncomplicated pregnancy, someone who has not had a prior fetal death, it's an option for patients depending on your healthcare setting, to be delivered then. But in a patient who has medical comorbidities or has lost a baby before, that's where we kind of push it a little bit more, because we just want the best outcome for you possible. And we know that, there's that your baby at that point, it's not like we would expect the baby to have problems breathing or eating or something on that, regard. We try not to deliver people much earlier than that without a reason. Um, Term pregnancy is technically 37 weeks. And so depending on the clinical situation, sometimes we go a titch earlier, but we know that 39 week is kind of it is a sweet spot.
Yeah.
You were talking about how you were starting to do the educational development of educational materials for the doctors and the patients. Is there anything else that you're working on or you're going to start working on that you would like to talk about?
Oh gosh, I have a lot of ongoing projects.
Which is awesome, which is great.
Probably too many, according to my mentors. But there's just a lot of different ways to tackle this. We have our ongoing cohort of women who have experienced stillbirth that we don't have like an end date on enrollment for that. I think the goal is just to collect as much information as possible and help these families through that experience. And then is part of whatever information's gathered in terms of their evaluation, we can meet with them, counsel them, and that's true for anybody.
Mm-hmm.
You don't have to sign up for a study for us to talk with you about what happened and make a roadmap for the future. But so we have that study going on. And then I have some work trying to look at different biomarkers that may or may not be helpful in identifying higher risk populations. There are projects going on looking at genetic contributions that might not have been previously recognized, using kind of the more advanced genetic technology. So there's a bunch that our division has in the works. We've been looking at, different placental abnormalities according to different medical conditions or maternal characteristics. So just trying to get a better idea of like, why is it that a mom with diabetes is at higher risk? Because we don't totally understand
Oh,
that
gotcha.
either. Yeah, stuff like that. So we have lots of things in the works.
That is great and hopeful. I feel like the research lends the opportunity of having more hope for babies to arrive here safely, I guess.
Yeah, I agree. I hope so.
Yeah. Well, Dr. Page, this has been delightful. This has been very informative. I've really enjoyed chatting with you and learning a little bit more. I feel like just looking back, I'm like, okay, I think we did okay. I think with our son, because he had a partial autopsy and we got a lot of information from the placenta. And I think they must have done some x-rays on him because we know that he had extra cervical ribs.
Mhm.
So yeah, it was just, I'm like, I'm glad we got some information from that. So
Absolutely. Absolutely. Yeah, I think that just any information is good, and then and then when the time is right, can think about doing it again.
yeah.
Yeah. And there's actually a really great study that looked at that in terms of, how long did people wait usually, and did that matter? And they compared women who waited less than a year to women who waited like 2 to 5 years or
Mm-hmm.
so, and outcomes in terms of like prematurity and, infants or like,
Yeah.
fetal and infant survival and all of that were equivalent. And so I think that that just speaks to the fact that when you feel ready,
Right.
assuming that your other medical situation is in tune, like if you don't have like out of control diabetes or something, assuming everything else is okay and that you guys feel like, gosh, I think we're ready to, give this a try. And that we're there to help you through that and to take it one step at a time together.
Yeah. Well, thank you again, Dr. Page, for your time and expertise, and also for the work that you're doing. Once again, super excited about the whole education to the providers, and also to help the patients out when they experience a stillbirth. So, thank you again.
Oh, thank you. Thank you for all that you are doing. This is an incredible tribute to your son, and I am just very honored to be a part of it.
Thank you. We are so grateful for Dr. Page. Wasn't that such a great interview? I learned so much from it. I don't know what you think, Lee, but I was really grateful that she came on, and I feel a little bit more armed on how to maybe even tell friends who may be going through this on what they can do in regards to having an autopsy. I don't know what you think, but
Yes, it was wonderful to talk to her. I felt like a little out of place sitting between two doctors.
No, it's all good. It was really helpful though. I thought it was excellent. So looking forward to hopefully more education actually for these families after they are coming upon something so tragic. So once again, thank you, Dr. Page. We really, really appreciate it.
Thank you again, Dr. Page. Head over to the website stillapartofus.com. There you can find the show notes, including a full transcript of this interview and any resources that were mentioned. There you can sign up for a short and helpful email newsletter. You can find out how to become a patron and support the work it takes to produce this show for just a few dollars a month. And lastly, there you can find out how to get in touch with us if you would like to share your child's story with us on the show. The show was produced and edited by Winter and Lee Red. Thanks to Josh Woodward for letting us use his song, Vanishing Note. You could find him at joshwoodward.com. Lastly, subscribe to this podcast and share it with a friend that might need it. And tell them to subscribe. Why? Because people need to know that even though our babies are no longer with us, they are still a part of us. I have learned from my mistakes, and I am sure I could repeat them exactly. Peter Cook.